Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
All right. Welcome, everyone, to our UCSF Sports Medicine Podcast, 68 Weeks with myself, Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown. Today, we're going to be talking about a very common injury that we see in both professional athletes as well as recreational athletes, as well as kids, ACL tears. As we all know, the anterior cruciate ligament is really important for doing anything that involves change of directions, being active, and playing sports. So there's a lot to cover today. Maybe the first question, Brian, I'll ask you is, even better than having us actually do surgery on it is if we can actually prevent ACL tears from occurring in the first place. So what's kind of the evidence, or what are things we can do to prevent the tears from actually occurring?
So I think the answer is both yes and no. So we can decrease the risk. And I think of ACL injuries as kind of two categories. One is kind of the non-modifiable bad luck. Like I was skiing, my ski caught an edge, and I felt something twist and heard a pop and then got an ACL tear. I'm not sure how much any injury prevention strategy is really going to help decrease those injury risks as all that much. The second one, I think, are the fatigue and coordination-based ones. And overall, those are much more common. Those are the ones we see in teens. Those are the ones we see in competitive athletes. And I think there are prevention programs. Most of those are based on core stability and jumping and landing kinematics. And they've been shown to be really effective, especially for female athletes. So I think the most common one is called the FIFA 11, or it might be FIFA 12 now, where it's basically a series of warm-up drills that can be performed either in a team or on your own. But when teams go through this, they tend to decrease their ACL risk by about 50%.
And what about in terms of what the ACL actually does? I talked about it a little bit, but Drew, maybe talk a little bit more about what the ACL is important for in terms of activities, maybe from a recreational athlete to someone who doesn't potentially even play sports.
Yeah, and so the ACL, it's one of the four main ligaments of the knee, and it sits in the middle of the knee. So it's a cruciate ligament. There's two that cross, and it runs from the femur to the tibia, and then it keeps the tibia, like the lower leg, from sliding forward, and then also from rotating too much. And it's really important for any activity where you're cutting, pivoting, changing directions. So if we think about soccer, basketball, where you're stopping, changing directions, and like when you stop, making sure that your leg doesn't keep going. And if without it, you just have that feeling of, when I plant my leg, I don't know if it's going to stop or not. I can't trust it. And then so you can't change directions, or when you do, your knee buckles. And then same thing with skiing, where it's, I try to turn and then my knee just goes on its own. It doesn't have that stability to it. And so, for some people, it can even, manifest with lower levels of activities like, changing directions while walking or going up and down stairs. But most of the time, those inline activities, people are okay, even with that ACL deficient knee. And then it's really those higher level cutting, pivoting, twisting, where you will notice its deficiency.
So, Nirav, we've noticed in the adult group that there's actually a higher number of patients in their older ages, in their 40s, 50s, and even 60s, getting ACL tears. And to a certain extent, that's, I don't want to say good, but it's not the end of the world, because it means older people are remaining more active. But in kids, we're also seeing a higher incidence of ACL injuries. So what are you seeing in the peds world?
No, that's absolutely right. I think, when I first started, 10, 11 years ago, the average ACL age for me in my practice was around 16, 17, and that's dropped down to 13 or 14. And I think a lot of that has to do with how kids are playing sports. 20, 30 years ago, kids were playing multiple sports. They were doing it for a couple hours a day, and they weren't really engaging in skill-based activity. They weren't trying to kick a soccer ball farther. They weren't trying to throw a baseball farther all the time. They were like, look, it's the fall. I'm going to play football. It's the winter. I'm going to play basketball. And what's happened now is that these young kids are basically doing these skills. They're training like adults and their bodies can't handle it. So they're tearing their ACLs. So I think as this trend continues, we're seeing younger and younger patients get these injuries. So for a lot of these kids, it is similar to the older adults. They're being more active, but they're being active in the wrong way. They're doing it to develop skills as opposed to, just being, free play or being active or doing seasonal sports. So hopefully a lot of us are all trying to change that trend so we don't see young kids who are tearing their ACL. And the one major issue with kids who tear their ACL is that because they're getting back to higher level activity. So, if you're 40, you tear your ACL, you may not want to be doing competitive sports anymore or doing something that's very vigorous. These 13-year-olds want to get back on their high school team and then they re-tear again. So we're trying to prevent these younger and younger patients from having a revision surgery when they're 18 or 19, as opposed to never tearing their ACL in the first place, or number two, getting that one surgery that lasts them for the rest of their life.
Yeah. So speaking of, Nirav, there's talk about doing ACL repairs rather than reconstructions. How is that different? And what are your thoughts on that in a PEDS population?
Yeah, I think a lot of people, when they said, they think of things getting repaired. So they say, oh, I got my ACL repaired. And actually, most of the surgeries are, I'd say over 98% are reconstructions, which means you're actually putting a new ligament in. With the repair, what ends up happening is that typically the ACL is pulled off the thigh bone side, which is the femur. So the ligament itself is good, but it kind of just pulls off. It's pretty rare that that happens because typically when you tear your ACL, there's so much trauma to the knee that the ligament itself gets damaged in addition to pulling off the bone. But if you do have that rare case where the ligament just pulls off the bone and you're able to repair it back, there are techniques you can utilize for it. But even now, when you look at that data, patients don't do that well with that surgery because there probably is some degree of damage to the ligament as well too. The one case in PEDS patients where it may actually work pretty well is when they actually pull a piece of bone off with the ligament, and that's called a tibial spine fracture. And with those cases, if you quote unquote are repairing that piece of bone back, patients do very, very well. But when you have a pure ligament that basically tears off and you're kind of sewing it back to the bone, even though you can technically do it, the outcomes aren't necessarily the best. So I think reconstruction, as I'm sure Drew will talk about next, is really the gold standard for how we fix these.
Yeah, I think it sounds really fascinating to be able to go in and just put in essentially what looks like a piece of suture. And the results seem pretty variable. It seems like you get lucky. Sometimes it seems to work for a few kids. We don't really use it too much for adults because the indications just aren't there. There is something called the BEAR trial that patients ask about, which isn't widely available, which also includes putting in a scaffold. So it's kind of like doing a repair in a very specific situation, but it's really not widespread or out there for widespread use yet. One of the things people also ask is, well, why can't I just get stem cells injected? And the problem is that stem cells, even if we had, let's say, ligament stem cells and injected them into the knee, they're not going to find a scaffold, walk up and down a ligament, and regrow an ACL. And I've had probably a few patients a year who have had an ACL injury, gone for a stem cell injection, and then we're kind of surprised that the ACL didn't regenerate in any way. And the reality is we're just not there yet. The ACL is a large structure, and injection of even tens of millions of cells aren't necessarily going to do anything for the ACL, and they're certainly not going to recreate knee stability. So Drew, when we talk about ACL reconstruction or giving somebody a new ACL, not everybody needs it, but what are the indications that we think about in terms of who needs an ACL reconstruction, who doesn't, and who do we bring to surgery most commonly?
So when you have an ACL tear, it's those activities, the cutting, pivoting, twisting, that will really potentially be limited in the future when you're ACL deficient. And so if you are, a basketball player, soccer player, skier, any other activity that has those types of movements, then I think the most predictable way to get back to that is with the ACL reconstruction surgery. And there have been a number of studies that show that people, they can function with physical therapy, but there will be a subset of patients where they just can't trust the knee, or the knee gives out again. And then what we worry about is if you go back to those, you feel good, your strength is good, you go back and then you have another giving way episode. Now you've got a meniscus tear, a cartilage injury, additional damage to the knee that, then can be even harder to correct. So the surgery, it's I think the most predictable way to get people back to, those types of activities, and then, especially like younger patients, like Nirav was saying earlier, it's hard to get them to stop those. And I think leaning towards reconstruction in that population is definitely the right way to go.
In terms of, with the various reconstructive techniques, a lot of people, especially now with more information on the internet, will ask questions about what type of graft are you going to use to reconstruct my ACL? And you've got obviously cadaver tissue, you've got quadriceps tendon, you've got hamstring, you've got patellar tendon. Brian, what do you discuss with patients in terms of what the ideal graft choice is, or what do you use when you're making those decisions?
I think for me, my guiding advice for patients is if you're over 35 and you're not incredibly active, meaning skiing 100 days a year, playing in a league multiple days a week, anything is going to work just fine for you. The success rates are about 92 to 95%, meaning you don't re-tear your graft over the age of 35. The advantage then is for allograft, you get back to work a little bit faster. The incision's a little bit smaller. You may be able to get back to taking care of your kids a little bit faster. So those important social determinants of outcome are really, I think, helpful. But I do go slow on the back end in terms of getting people back to sports. It's closer to 9 to 10 months rather than 7 to 8 to 9 months. But the reality is that if you're over 35, you're not really trying to get back into a league necessarily. Most commonly, you're trying to get back into skiing or some recreational sport. For younger people under the age of 35, for the most part, unless they're really not very active, I will almost always try to convince people to use their own tissue. Within that, there's three commonly chosen tissues. One is hamstring, which is the one I choose the most. Second is patellar tendon, which is the central third of your patellar tendon, and then a little piece of bone on either side. That's probably the one I use least. And the one that's talked about the most right now is quadriceps, both because it's old, we used it for a long time, but now that there's new fixation strategies, it also feels new. So there's a lot of information online about people who used quad tendons. Head to head, there's very subtle differences. You're always going to rob Peter to pay Paul. I don't actually know what that means, but it seems to make sense that if we're going to take a little piece of something out of you, I want the one that is going to have the least effects on athletic performance and daily activities when the success rates are pretty much the same. And so for me, that means for the most part, I'm going to use hamstrings as my first graft choice, quad second, bone patellar tendon third, but that's also my training and what I'm most comfortable with. What about you, Drew?
Yeah, I agree that, so I think the biggest important thing is that, especially in younger patients, using their own tissue is always better than allograft. And so it can make a big difference in re-tear rates, failure rates. But then amongst those three, I think they can all make a good graft. I think, most commonly around the world, the two most common are the hamstring and the patellar tendon. I think if you look at a lot of elite level athletes, like they'll get the patellar tendon reconstruction. And personally, I like that you're taking a little piece of bone on each side, and then you have like a bony healing. And I think it can, give a nice stable knee and maybe be able to push them a little earlier, especially for, an athlete looking to return to a specified season. And then, I think the quad makes a great reconstruction too. And, on the surgical side, sometimes we run into issues with the size, but the quad is a pretty predictable size, which is always, nice to have.
Yeah. So Nirav, it's hard to have a discussion about grafts without it going into a 3-hour conversation. Yeah. But what is your go-to in terms of your like high school varsity athlete? Maybe we'll play at the next level, maybe not, which is a majority of the people that we see. What is your choice and why?
Yeah, so I definitely veer away from allograft, as we talked about, for all those reasons. So definitely don't use allograft unless there's some sort of issue with their own tissue. I think initially early on, it was doing a lot of hamstrings, but I think there's more data, particularly for kind of higher level athletes, to do bone, patellar bone, or quad. I think probably the biggest kind of the biggest differentiating factor I feel is that for kind of male collision athletes, those playing soccer, football, I'll do a patellar tendon reconstruction. For female athletes, just because they do have a higher rate of anterior knee pain from the patellar tendon reconstruction, I've switched to doing primarily quads for them. And there's pretty good data now to suggest the quad is superior to hamstring in kind of that adolescent female age group. So I pretty much am offering either patellar tendon or quad for most of the kind of the higher level athletes. But if I get a high school kid in who's going to just be playing rec sports or does something kind of like, for a couple months a year, then I'll do a hamstring. So I'd say I've kind of veered now to about 65% quad and then an even split between BTB and hamstring for the other kids. So I agree. I think, a lot of it is splitting hairs. It's a lot of times the families will come in, requesting a certain graft and, barring them asking allograft, I think it's a reasonable thing to do any of the grafts on them, but just understanding, particularly for female patients, the risk of that anterior knee pain with patellar tendon that they need to be aware of.
Yeah, I think for me, I tend to do more hamstring, but I tend to have more skiers and more people that are seasonal athletes. And I like the fact that the hamstring is, at least for me, is the most predictable harvest, especially for patients that are a little bit skinnier and shorter. We can always triple over the hamstring. Whereas with a quad tendon, if you are a short patient, sometimes the quad can be a little bit small, and sometimes the bone patellar tendon bone can have a little bit of what we call graft tunnel mismatch, where you end up with the bone kind of sticking out on the other side. The reality is when we look at these, when you have good surgeons doing these, the success rates are all pretty similar, and they are pretty subtle differences. So one of the things that's come up in the last 5 years, again, is doing something called extra-articular tenodesis, or ways to augment the ACL. So Drew, can you explain in layman's terms, so like you're explaining it to me, what is an extra-articular tenodesis and why do we do it?
Yeah, so the ACL, like it keeps the tibia from sliding forward, and then also contributes to the rotational stability of the knee. And the thought behind the tenodesis, what you're doing is you're taking a piece of the IT band, the iliotibial band that runs on the outside of the knee, and then it runs from the hip down to the tibia, and then you're taking a piece and attaching it just to the femur, just above the knee joint, and kind of restraining how it rotates. And it's almost like a check rein against the ACL. So it's one more structure to give a little more support to limit the rotation of the knee. And there have been a few recent studies, a lot of recent interest on adding that to an ACL reconstruction. It was something that before we could do ACL reconstructions, people would do just that because it does control that stability of the knee. But it fell out of favor because that alone didn't work well. But in adding it, it seems like it does decrease the re-tear rate for the ACL. We're still trying to figure out if it has detrimental effects. So it may not be right in every patient, but by doing that, it's just like almost like belt and suspenders. You're adding just like an extra level of support, and hopefully for those patients who are really at risk for re-tearing. So I'll personally use it like if somebody's already failed an ACL reconstruction, or if they're really like their ligaments in general are really loose. I think adding that can limit that risk that they're going to have to go through the ACL reconstruction again.
Yeah, I think that's my indications are there kind of things that we can't really correct. So is there something about your bone shape that we're not going to change at the time of surgery? Then I think it's reasonable to add that in. We know that some people that have different shapes of their femur, different shapes of their tibia, or how their slope is changed, may be at higher risk for re-injury. I typically don't use it too much for primaries just because there isn't that much evidence. So I'm going to ask the final question. Why do we wait 7, 8, 9 months for people to go back to play sports? And what do we really look for in terms of saying it's time to go back? You're as safe as you're going to get to go back. Nirav?
I think the way I like to describe it to people is that, there's kind of two parallel processes occurring. One is the physical therapy part where you're developing your strength and doing all the rehab so that you have a strong knee that can kind of support your ACL. And then there's the biological part where the new graft we have to put in has to heal to the bone. So for a lot of these, especially the younger patients that I see, like they'll feel pretty good at 3 to 4 weeks. They're like, I feel good. I don't have any pain. Why can't I go back to sports? And it's really about describing the fact that it takes that long, number one, for the ligament to heal to the bone. And then number two, it does take a long time for that strength to come back. So in order to be able to cut, to be able to do the agility movements, to be able to get that strength back from the injury, it takes that period of time. So a lot of it is those two parallel processes: getting the strength back and then getting the graft to heal biologically. And I think the trend is now starting to show that for mechanics and how people are feeling when they get back to sports, sometimes those mechanics take maybe even up to 18 months to get back. So I think there's a little bit more of a push to kind of maybe draw that line back to 12 months, particularly for higher level athletes, as opposed to get people back quicker. How about you, Drew? What's your kind of, when you're telling patients why they have to wait that long?
Yeah. And because I totally same thing. And I think the hardest part is that feeling early on that like, hey, but I feel good. And like my strength is coming back. It doesn't hurt. Like my knee feels stable with these lower level activities. I feel like I could push it and do more. But what we know is that the ligament isn't fully healed. And from the time you put that tendon in, your body converts it from a tendon structure to a ligament structure. And it involves breaking it down first and then building it back up. And so there's actually a period where it's weaker early on. And so part of the recovery is the pain, that goes away pretty quickly. Part of it's the muscle strength, the coordination. And then part of it's just giving that structure time to rebuild itself and, get strong enough to then, when you do stress it by pivoting, that it doesn't either stretch or re-tear. So I'll tell people minimum 9 months, but then the rest is based on their strength and coordination. And even if they have it before then, still can't push ahead. But, if that isn't there, then, need to wait for that because that's an important part of it.
Absolutely. Yeah, no, we could do a several series podcast on ACLs. So much to talk about. Even the rehab is just like several hours worth of discussion about what can be done. But to keep it short, once again, thanks everyone to listen to our podcast on ACL surgery and ACL reconstructions. We look forward to having you listen to our podcast moving forward. Thank you.